Huntington's disease by Cameron Liles. The structure of this presentation will be as follows. First, we will look at the pathophysiology, followed by the effects that it has on movement control, current treatment and interventions, benefits of exercise, and guidelines for exercise prescription. Huntington's disease, or HD as it will be referred to in this presentation, is a neurodegenerative disorder that is hereditary. It has been classified as an autosomal dominant trinucleotide repeat disorder and results in abnormal expansion of cytosine adenine guanine CAG repeats in the Huntington gene and destruction of striatal and cortical neurons. The disease affects motor control of both fine and gross motor skills and is often referred to as Huntington's chorea. This term is derived from the Greek word which means dance and is characterized by the body producing jerky, involuntary movements. Some common symptoms of the disease include cognitive dysfunction, psychiatric deficiency, chorea, and disturbances of gait. Although the disease has been widely researched, there is still no cure, and treatment is often limited to palliative care. The prevalence of HD worldwide is 1 person per 20,000 and does not discriminate between gender. The average onset of the disease is 40 years of age. Etiology. In 1993, the HD Collaborative Research Group discovered that Huntington's disease was caused by the presence of an expanded and unstable CAG repeat in the IT15 gene on the short arm of chromosome 4. As previously stated, HD results in abnormal expansion of CAG repeats in the Huntington gene and destruction of striatal and cortical neurons. The striatum is particularly vulnerable to the disease process, with selective loss of medium-sized spiny projection neurons and relative sparing of interneurons. The neuropathy of HD is described by atrophy and a rapid increase of astrocytes in damaged areas of the central nervous system, more often than not involving the basal ganglia. Other regions affected, but not as much as the basal ganglia, include the claustrum, subthalamic, nuclei, and hippocampus. The loss of neurons begins in the striatum, with the most severely affected area the mesial region of the caudate, with subsequent involvement of the putamen. Pathogenesis. Recent studies surrounding the pathogenesis of HD have implicated a defect in the mitochondrial energy production that may predispose a specific subpopulation of neurons to excitotoxic injury. Some evidence of this research includes elevated lactate levels in the brain of those with HD, which is measured by magnetic resonance spectroscopy. There was also striatal and cerebral cortex hypometabolism observed using fluorodeoxyglucose positron emission tomography. The third discovery in this study was in the caudate and reported that there was a decreased activity of complexes 2 and 3 of the mitochondrial respiratory chain. Impairment in the mitochondrial energy production may predispose affected neurons glutamate-mediated excitotoxicity. Hence, glutamate is a primary excitatory neurotransmitter in the central nervous system and acts through ionotropic and metabotropic receptors. Excessive stimulation of the NMDA receptors, which are part of the ionotropic receptors, may be neurotoxic. Studies have found deficits in working memory, attentional set shifting, and visual recognition memory, all of which are related to corticostriatal information processing. Slow processing speed and reaction times have also been shown in Huntington's disease patients, which show up in pre-HD disease and progressively worsen as the disease worsens. Clinical course. Average age of onset is 40 years of age, but can be as low as 2 and as high as 70. Average years of survival is 16 years of age, but can range from 2 to 43 years. During the early stages of HD, there is evidence to support that there is alteration of neuronal, especially synaptic protein expression and function. The reduction in these neurotransmitters and proteins involved in synaptic transmission are prevalent in the human HD brain, even at early stages with little or no cell loss. It is mainly comprised of a triad of symptoms, including cognitive, motor, and psychiatric disturbances, along with a reduction in body weight. The most striking symptom early on in the disease course is chorea, which involves excessive spontaneous movements irregularly timed, randomly distributed, and abrupt. As the disease progresses, chorea movements may cease, while more rigidity occurs. Mental disturbances are also a large symptom involved in HD. Some of these include depression, anxiety, low self-esteem, suicidal thoughts, and hypomania. Irritability is also very common and results in aggressive outbursts, often directed towards partners. Functional capacity slowly declines as a result of increasing motor, cognitive, and psychiatric deficits, until the patient becomes immobile and bedridden. Patients suffering from HD usually die from aspiration pneumonia, resulting from dysphagia. Effects on movement control. As discussed above, Huntington's disease has three main effects on the body. Psychiatric decline is not directly associated with movement, and cognitive decline, while it may play a small role indirectly in movement control, is not the major symptom concerning movement. As stated above, chorea is the most striking aspect that affects movement control of patients with HD. It causes the muscles of the body to produce excessive, spontaneous, irregularly timed, randomly distributed, and abrupt movements of limbs. This has a negative effect on exercise and makes most forms of physical activity difficult, as movements occur randomly without notice and cannot be controlled in a manner as would be appropriate for many forms of physical activity. Along with chorea, Thompson explains that in addition to chorea, those suffering from HD have a decline in voluntary motor performance function. He showed that wrist flexor exercises over 15 and 60 degrees were slower than those without HD, and they also produced a more variable result. This shows that HD sufferers have a reduced power output, which has many negative implications on exercise. It affects the ability to train at certain intensities and maintain lean muscle mass as well as bone density. It also reduces the types of activities that can be performed, i.e., fast explosive training is hindered due to the extended time for muscle contraction. Treatments and interventions. Van Voort and Roos explain that in theory, chorea should be reduced by blocking the nigrostriatal dopaminergic transmission, which is a pathway associated with motor control. Other studies have shown that Respiron, a dopamine-depleting agent, has been successfully used in HD patients. It was shown to significantly reduce the involuntary muscle contractions that are experienced during the disease. However, Respiron, which is a presynaptic dopamine receptor, has been shown to have adverse effects, which include depression and sometimes to increase the intensity of manual dexterity, which is the ability to skillfully use the hands. This is a problem in patients with HD because depression is already one of the major symptoms associated with the disease. The benzoquinolysine, tetrabenazine, on the other hand, is a postsynaptic dopamine receptor and has also been shown to have positive effects on reducing chorea. It is believed to be the more effective of the two treatments, but cannot be confirmed as studies have only included a small number of patients and have been short-term. Benefits of exercise and guidelines for exercise prescription. Quinn et al. Suggest that it is still relevantly unknown as to what extent strength training benefits HD sufferers, although he does suggest that other studies have shown that exercise programs can result in a reduction of falls, improvements of balance, flexibility, physical functioning, and walking performance. There are a few problems HD patients have to overcome in order for the program to be successful, and some of these include cost, as long-term physiotherapy over the span of several decades is highly unrealistic and in most cases not feasible. Motivation and adherence are also large barriers that need to be overcome in order for exercise to be a beneficial intervention, due to one of the side effects of HD itself being a lack of motivation. It is crucial that the carer is committed and can provide relevant motivation and support where needed. Once these issues are overcome, then studies have shown that exercise can be beneficial in a number of ways. Khalil demonstrated significant improvements in a range of different activities, including gait speed, balance, and physical functioning. This study was also a relatively short one, which suggests that a long-term program that is sustainable could lead to further improvements and benefits. Their program included having clients perform specific exercises designed for HD sufferers and included 3 sessions per week for 8 weeks in total. In comparison to Liles' study, which was a long-term feasible home-based exercise program, Zinzi performed a study that investigated the effect of an intensive exercise program that consisted of a 3-week cycle at a rehabilitation centre 3 times per year for 2 years. The results from this study showed immediate, highly significant improvements of motor performance and functionality in activities of daily living. The study also reveals that there was a very low admission rate to nursing homes and rehabilitation centres within the time period of the study, suggesting clients were able to maintain a functional level of performance. This is relevant in terms of HD because one of the major symptoms includes a decrease in functional motor performance. To conclude this presentation, we have to remember that HD is a neurodegenerative disease that causes expansion of CAG repeats in the Huntington gene and destruction of striatal and cortical neurons. There is no current cure for the disease and it ends in fatality. It affects motor performance, and one of the primary indicators of this is the presence of chorea, which is described as a random involuntary movements of the limbs. Along with chorea, HD causes cognitive and psychiatric disturbances, which can lead to anxiety, depression, suicidal thoughts, and even aggression. The average age of onset is 40 and the average survival rate is 16 years. However, there are treatments that have been shown to increase quality of life and delay the onset of symptoms. Some medications include Respirant, which has been shown to lessen the chorea associated with the disease, but there are negative side effects that come with the intervention, which include an increase in manual dexterity and also increased feelings of depression. Along with the medical interventions available to treat and manage Huntington's disease, recent studies have found benefits coming from exercise programs. 2 separate studies have shown that there is an improved functional capacity deriving from both a long-term feasible home-based exercise program with an intensive exercise program that lasts for 3 weeks and is performed 3 times a year. This information is very promising, and further research in this area would be beneficial in finding new ways to treat and manage the symptoms associated with HD to help improve and even extend the quality of life for those sufferers.